It's the PainExam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the PainExam newsletter at PainExam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the PainExam app with a premium subscription or access for free with a CME subscription at PainExam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back to the PainExam Podcast. Really happy to be here. We have a lot of great stuff coming up, as I mentioned before in previous episodes. ASPN in Miami this summer, co-directing the Ultrasound Regenerative Medicine course with Ali Valley Moed, as well as we have Pain Week in September. It's going to be great. I'm going to talk about AI in pain medicine, how it's reshaping our practice, as well as ultrasound, of course, in pain medicine, image-guided techniques. So lately, I've been doing more ultrasound courses. We now are doing them in Costa Rica quite frequently, as well as in New York. And if you're interested, just go to nrappain.org or shoot me an email at info@nrappain.org, and I'd love to see you there, as well as private coaching for the pain boards. So if anyone is interested, let me know, and I could go over the details. Anyway, in the meantime, let's get back into the board prep, because this is board prep season, and a quick review of complex regional pain syndrome. The boards are always going to ask how you make a diagnosis. The answer is Budapest criteria, which for CRPS 1, that's RSD, right, is 1, continuing pain that's disproportionate to the precipitating event. 2, at least one of these signs in the one sign in 3 of the following 4 categories by history: sensory changes, hyperesthesia or allodynia; vasomotor, temperature abnormalities, asymmetry, skin contour, skin color or changes or asymmetry; pseudomotor changes such as edema, sweating, changes, asymmetry; and motor or trophic changes, decreased range of motion, weakness, dystonia, hair, nail, or skin changes. And then in the next category, at least one sign in 2 of the following 4 categories by exam: sensory, evidence of hyperalgesia to pinprick or allodynia to light touch, temperature, sensation, deep somatic pressure, or joint movement; or vasomotor, evidence of temperature, asymmetry over 1 degree Celsius, skin color changes, asymmetry; pseudomotor, evidence of edema, sweating changes, asymmetry; or motor trophic changes, such as evidence of decreased range of motion, weakness, tremor, dystonia, hair, nail, or skin changes. And 4, there's no other diagnosis that better explains the symptoms. So CRPS is a clinical diagnosis based on history, physical. There are variations between practitioners and studies. The incidence varies between 5 and 26 per 100,000, and a mean age of diagnosis of 12. The lower limbs are more commonly involved than the arms. The mean age of diagnosis of 12 is a little surprising to me. I'm not sure about that. That's what I'm seeing in this reference that I'm going to post, but I don't recall that being true, so just take that with a grain of salt. There is a higher incidence in females, 4 times more common; Caucasians, higher social economic status, depression history, headache history, and history of drug abuse. So what causes it, we really don't know specifically. However, there are mechanisms suggested that include central sensitization, alterations in the central nervous system, and small fiber changes. Pro-inflammatory states may also play a role. Patients with CRPS, they have a higher level of plasma cytokines, chemokines. Fractures are a precipitating event in about 5 to 14% of the cases, as well as surgical procedures in 10 to 15%. Stress has been shown to play an important role in introducing perpetuating CRPS. Children with CRPS find school more stressful. They have a tendency towards overachieving and may have learning difficulties, or more likely have had recent psychological stressors. So the way you treat it is pain relief, which can improve quality of life. Of course, that's easier said than done. It's an individual treatment. There's little evidence the effectiveness of any particular treatment modality. Invasive injections and blocks do have varying degrees of effects, and typically, classically, they work earlier than later. Intensive physical therapy is the gold standard, and a single-blinded, randomized controlled trial of intense physical therapy combined with cognitive behavioral therapy for children with CRPS showed a significant movement on 5 measures of pain and function with sustained benefit in 25 of 28% children involved. Graded exposure to exercise and patients with CRPS are harmful and can be graded exposure to exercise that patients with CRPS think are harmful can be beneficial, reducing pain, fear, in turn leading to reduced disability and pain. Biofeedback, isometric strengthening exercises, and recreational therapy can be helpful. CBT has also been helpful in these patients. This link is mainly for children. I'll post it, so that's probably why they're talking about the mean age of diagnosis in children is about 12. For adults, the mean age of diagnosis is 40 to 50 years old. That sounds more right. And believe it or not, you can see it in elderly people. I've seen it after knee replacements. And because I had a bias that this is a disease of younger patients, I didn't really think of CRPS right away. But if someone has their knee replaced and they're having allodynia hyperalgesia, you definitely need to consider CRPS even if they're 80 years old, which is not the common finding or the common age that we typically see the disease in. So, the high-yield board questions will typically ask for physical therapy as the most important therapy, neuropathic meds, gabapentin, tricyclics, interventional, sympathetic block, spinal cord stimulation. I had a patient in the office yesterday with CRPS, and he was sent by his PT and his other doctor, his orthopedic, and basically they couldn't do the PT because he was so tender, inflamed, pain. It was too much pain for him, limited range of motion. He had everything I mentioned in the Budapest criteria, so therefore I'm going to first start with the sympathetic block. He's only a month out, so I'm hopeful that he's going to recover. The problem is when patients wait too long, and it makes it more challenging for the nerve blocks to work. And CRPS unfortunately can spread to other limbs. I remember being a fellow and we had a nurse who had her finger banged with an IV pole, and the disease spread up that arm to the other arm and then to her legs. She was in a wheelchair because her finger got banged by an IV pole, which is absolutely nuts. She wound up getting a spinal cord stimulator in her lower back, upper back. It helped her quite a bit. She got her life together, got married, went back to school, got her degree. So it's kind of really messed up disease, right? Anyway, so what is required for CRPS diagnosis? Well, Budapest criteria. First line treatment, physical therapy. Once again, CRP2 differs from one by the presence of a confirmed nerve injury. So these are the most common things they'll ask you on the pain boards, and hopefully you'll ace it when the time comes. Now getting into intrathecal drug delivery systems, some things I did early on in my career. I don't really do much of this now. Indications, failed back surgery syndrome, cancer pain, refractory neuropathic pain. I'd say cancer pain was the most common. I'm not the most knowledgeable person when it comes to intrathecal drug delivery systems. I tend to refer these patients out. So if I'm saying something wrong, please call me out. But this is pretty basic stuff. The medications we typically use, first-line therapies, are the morphine or ziconotide, which is not an opiate, and baclofen for spasticity. The ziconotide is more for neuropathic states. Complications, infection, catheter malfunction, and granuloma formation opioids, which typically will occur with the higher concentration opioids. Trialing is required before implantation. There can be bolus or continuous infusions. Ziconotide, unlike the opiates, does not cause respiratory depression. Always monitor for withdrawal with pump failures. And keep in mind that they may ask a board question where they missed the pump when they went to fill it, and then the patient overdoses, and what is the management. So they may ask you what to do in case the medication doesn't go into the pump. So, of course, monitor the patient, manage the airway, assess for withdrawal or for overdose, right? If they're having a large concentration of morphine, it's 100 to 300 times more potent than oral morphine. So if the pump has been empty for more than 48 hours, the patient may have lost opioid tolerance. The initial dose upon restarting should be lowered and titrate cautiously. But in terms of the medication missing its target and going into the subacute tissue or muscles, you need to watch that patient's airway. You may need to give them Narcan, but remember, the Narcan does not last that long, so keep a close eye on this patient. They should be admitted to the hospital and observed for quite a while. Catheters can be broken, disrupted. This requires surgical replacement. And you might need to bridge patients who are not getting their dose if the pump fails or if there's an empty reservoir. Any delay over 48 hours, you have to start at a lower dose, and catheter should be cleared of stagnant drug by flushing or aspirating from the catheter ports. And make sure you have the ability to monitor these patients. And lastly, the board may ask about ziconotide side effects. Common side effects include nausea, dizziness, confusion, gait disturbances, and somnolence. The most common are dizziness and nausea. Once again, it's a potent non-opioid intrathecal medication for severe chronic pain, and it can cause nervous system side effects. So just keep that in mind. And to review, ziconotide is derived from the venom of the marine snail, the cone snail, Conus magus, and it acts as an N-type voltage-gated calcium channel blocker, inhibiting pain signals in the spinal cord. Thanks for listening. I hope this has been helpful. Good luck on the boards, and hope to see you at the conferences or my courses.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.